Thanks a lot. Good afternoon, everyone. Nice to be here in Latur. Shall we just start presentation? Yes. Okay. I will start with the disclaimer. So it's a standard disclaimer that both organizing secretary have been my roommates, but over last 20 years association, I haven't benefited financially yet. Okay. All right. Coming to the academics, so I was given the topic HFNC versus CPAP, but I have taken the liberty to change it to CPAP and HFNC because they are used in association with each other, not against each other. So both of these are modes of non-invasive ventilation. CPAP is one of the most important respiratory support for preterm neonates. It helps by keeping lungs open. It also reduces the need for mechanical ventilation and eventually reduce incidence of bronchopulmonary disease. So in a preterm baby, it is used for treatment of hyaline membrane disease after extubation from mechanical ventilation as a respiratory support and for treating apnea of prematurity. CPAP helps in prevention of mainly the obstructive part of apnea of prematurity, whereas caffeine is important for preventing the central component of apnea of prematurity. So CPAP setup, it comes in like various types. You can use a generator for CPAP. So the commonest being the bubble CPAP. Bubble CPAP uses a variable flow. There is an underwater seal. You can use a ventilatory CPAP. The flow from ventilator is used to generate the pressure. And then there is a variable flow CPAP or infant flow driver, which we usually see in machines like SLE. So bubble CPAP and ventilatory CPAP are the most commonly used machines. Now, how does the pressure get delivered once it is generated? Through the tubings, it goes to nasal prongs or a mask or some other interface. Some companies call it nasal pillow as well. This is the typical CPAP assembly. First, you have to have compressed air and compressed oxygen supply. Then it goes through the blender, and from the blender, it goes to humidifier, where it gets heated and humidified. And then through the tubings, it is applied to the baby. And then the expiratory limb goes into the bubble generator or water chamber. What are the initial settings? It's a PEEP of 5 centimeters is very standard practice, but certain centers use higher PEEP of 6 or 7 based on the oxygen requirement or work of breathing. Flow, we use around 5 liters per minute, but we can use higher if you want to give more pressure. And FiO2, we have to have a targeted SpO2 just to make sure the child needs minimal FiO2 to reach the targeted SpO2. And how do we increase the support? You can do it by increasing the PEEP by 1 centimeter at a time, or also you can increase the FiO2 by 5 or 10% each time. Monitoring is the most important and tedious job while baby is on CPAP. We have to make sure that the nasal prongs and mask, they are properly fitting. Otherwise, there will be sealing issues and leakage, and there won't be any good pressure generated. We have to also avoid excess pressure on nasal columella, or if you are using a mask, you have to make sure that there is not much excess pressure on the nose. We have to also ensure that there is an adequate water level in bubble generator and humidifier. Now, how does CPAP work? It prevents the de-recruitment of alveoli and also prevents the collapse of small airways. CPAP also helps by conserving surfactant by reducing the protein leak associated with atelectasis. So previously, all babies with respiratory distress syndrome were given surfactant, but then we realized that just giving them CPAP also can make sure that the surfactant production continues. The process of endotracheal intubation itself can cause so many problems, so just giving a CPAP can avoid intubation and prevent all these complications. And as I said, CPAP also helps in reducing the incidence of obstructive apnea. So when to apply CPAP? If you have to apply CPAP, apply as early as possible. Don't start on baby on high flow, just head box oxygen and wait for respiratory distress to worsen, and when the oxygen requirement already goes high and there is atelectasis. So if you start CPAP late, then you will have to apply higher pressure, you may have to give surfactant, you may have to give mechanical ventilation. So you have to start CPAP as early as possible. Nowadays, in fact, a delivery room CPAP has been recommended especially for extreme preterm babies so as to reduce the need for mechanical ventilation. And CPAP before and after administration of surfactant. So administration of surfactant in least invasive way or minimally invasive way, or by ensure technique, that is intubate, give surfactant, extubate and put on CPAP. For all these three techniques can be preceded and followed by giving CPAP. By doing this, the incidence of chronic lung disease will be less and the need for mechanical ventilation will be lesser as well. But the CPAP comes with its own issues. As we can see, there could be facial injuries because we try to give a lot of pressure to maintain the seal, and this can cause damage to nasal septum or columella. So instead of nasal prongs, we started using facial mask. But the mask also comes with its own issues because the skin of an extreme preterm baby is very fragile. So anything that causes the pressure on bridge of the nose can cause ulceration of the skin, as you can see in the first picture. However, over a period of time, these injuries do heal, and we can reduce the incidence of this injury by persistent monitoring, and you can periodically release that mask so that there is no persistent pressure. Okay, so what we have to look at, as you can see in the second picture, we do apply these kind of protective dressings so that the pressure is not applied too tightly to baby's nose, and you have to make sure that there is persistent bubbling of this machine here. So if there is a CPAP running in your unit, this noise has to be always around. If there is no bubbling, means the pressure is not being delivered to baby, and you may have desaturation and increased work of breathing. Now, there are few other issues with CPAP. Setup for CPAP needs experienced nursing staff, and the pediatrician or neonatologist himself or herself has to be very comfortable in using CPAP. Sometimes if the nasal prongs get dislodged, then there is no pressure generation, and also it increases the nursing time. But remember, all these things are there if you compare it with just plain oxygen. A baby who's on mechanical ventilation will have even more requirements compared to this. Another problem with CPAP, we all know, is CPAP belly, the distension of stomach, which happens because of the air which goes in the stomach. But that can also be easily tackled by inserting a feeding tube in the stomach. And also there is a concern about increased incidence of pneumothorax with CPAP usage. But see, all these studies, they come from 70s and 80s where CPAP was compared to high flow, just to the head box oxygen. And also this was in pre-surfactant era. So if a baby is likely to have pneumothorax, then this baby will have it whether the baby is on CPAP or a high flow or mechanical ventilation. So in fact, usage of CPAP helps in avoiding all these things rather than causing it. So in short, CPAP reduces the need for mechanical ventilation, especially in preterm infants. CPAP can be applied by various masks and tubes and prongs with various sources, whichever way you are comfortable with. And there are minor issues associated with CPAP, such as facial injuries, but the benefits far outweigh the risk associated with CPAP usage. Now, coming to the other modality, humidified high flow nasal cannula. So in short, we call it HFNC. So how did one start using humidified high flow nasal cannula? So initially it was used for infants with bronchiolitis, and where it was shown to be useful. And also whenever the nasal prong plain oxygen was given for more than 2 liters per minute, there was some pressure beneficial effects. That's why people got interested in using HFNC, and then we came to realize that it is definitely a better choice than a hood or head box oxygen. This is the typical setup. There is a blended air which comes through the wall supply. There's a humidifier. So this and tubing, this is almost similar to CPAP. Only change is the way the nasal cannula is applied. So the cannula in high flow is short and taper at the end, and it should occupy less than 50% of the diameter of the nostril. You have to remember this. There should be free flow of gas around high flow nasal cannula. Otherwise, there will be increased chance of pneumothorax. And the flow, what flow rate we should start? If you want to call it a high flow nasal cannula, it has to be more than 2 liters. Otherwise, it is a low flow system. So we start around 4 to 6 liters based on the gestational age and the severity. Maximum flow rate for preterms, as the manufacturer recommends, is 8 liters per minute. So this is one commonly used OptiFlow system, where you can see in the flow rates column, you can use the flow rates between 0.5 to 8 liters. But as I said, when you are using it for a fly flow, we start with 2 liters or more and then go up to 8 liters per minute. Why high flow and why not low flow like the nasal prongs, like in this baby, how we use it? That low flow is not heated and humidified, and we would be giving very dry oxygen and gases to the baby, and this won't be tolerated well. The nares will become dry and they are prone for bleeding. So in our initial usages, when we started using that bottled CPAP without humidification, lot of babies used to have trauma and obstructive apnea because of the crust formation and bleeding, and many times babies used to go on the ventilator because it was not properly humidified. That's why we have to not just humidify, we have to heat it also at appropriate temperature, which is 34 to 37 degrees. So heating and humidification, it avoids airway mucosal injury and it is tolerated better. So how does HFNC use? Compared to CPAP, which is a closed system. So that's why the nasal prongs have to be tightly fitting. But high flow nasal cannula is open system. We have to set a flow that is good enough than the respiratory demand of the baby, and it just reduces the dead space. When with increasing high flow rate, sometimes it delivers dynamic airway pressures as well, like CPAP, but it is not reliable and we can't quantify it. So how do we manage a baby who's on high flow nasal cannula? So if baby is having lower SpO2, we have option preferably to increase the flow rate, say by 1 liter per minute or so, and then followed by that to increase FiO2. And how to wean? We can reduce the flow rate by 0.5 to 1 liter every 12 to 24 hourly based on gestational age or birth weight. So if the baby is extreme preterm, we would go slower, say 0.5 liters every 24 hours or so. And the temperature, as I said, has to be maintained between 34 to 37 degrees. So in the conventional humidifier, you can use the non-invasive mode for that. What are the advantages? Simple and easy setup, very friendly while giving kangaroo mother care. Nurses and parents, they feel that it is very comfortable for themselves and babies to handle, and there are fewer issues with nasal irritation and septal damage compared to CPAP. Now, what does the evidence show about humidified high flow nasal cannula usage in neonates? Most of the trials show that this modality is useful for babies who are born at gestational age more than 28 weeks or birth weight more than 1 kilo or so. And most of these trials have been conducted in overseas, but there are Indian studies also. All these trials are non-inferiority trial. Non-inferiority means already the study has assumed that CPAP is the gold standard. So they are just trying to prove that high flow cannula is just good enough as CPAP, not better than that. But one interesting trial that is ongoing is giving high flow nasal cannula during intubation, because during intubation we stop bagging or we stop oxygen because we have to intubate the baby. But if the high flow cannula stays in the nose while we intubate orally, there will be less chances of hypoxia and adverse event. So we will come to know what are the results of these trials. Now, HFNC also comes with its own issues. So we cannot monitor how much pressure HFNC is giving. So that's why we don't keep on increasing the flow rate. We don't know what happens when we increase flow rate beyond 8 liters or 9 liters or so. And there is no safety valve. Like CPAP has got a safety valve with a pressure manifold. And there are no alarms. So with the bubbling, we know that the CPAP is working. With high flow, it's very silent thing. So we don't know whether it is getting delivered, or when the prong is out, we don't know how much pressure is, the flow is going. And this also can cause distension. And it is not the safest, because with higher flows, you can get barotrauma as well. There are case reports that a nasal prong has caused injury to nasal septum and also has caused pneumoencephalus, that is the air in cerebral sinuses. And since it is a relatively recent and newer modality, the protocols for weaning have not yet been established widely. Now, coming with the issues of both the system. Both systems we can't use if they don't have good spontaneous efforts. For CPAP and HFNC to be successful, babies have to have good spontaneous efforts. Modes such as NIPPV, which is a recent mode, here you can use on those babies who don't have great spontaneous efforts as well. Reducing, so if baby is breathing through mouth, the efficacy of CPAP or HFNC is reduced. Both can cause barotrauma, and both can't be used in conditions such as a diaphragmatic hernia and choanal atresia, which are untreated. Now, when we compare both modalities, what do we see? So CPAP can be used at all gestations, but HFNC is likely to be more successful if you use beyond 28 to 30 weeks. Available evidence shows that CPAP is gold standard for respiratory support for HMD, whereas high flow nasal cannula is just as good as CPAP or non-inferior, mainly in early or late preterm. But HFNC has got easy setup, nice comfort for nurses and parents, and minimal cosmetic issues. But if CPAP is not working, we have to put on baby on mechanical ventilation. But for HFNC, there is another step. You can put baby either on CPAP or mechanical ventilation. Now, what do we do? So, because we have to use all these things, and it has both CPAP and high flow has got their own advantages and disadvantages, we preferably use CPAP for respiratory support, starting with extremely low birth weight as well as late preterm and early preterm. We use HFNC as a primary support without CPAP usage for bigger children. We also use high flow nasal cannula as a weaning from CPAP, especially when babies are relatively stable and we have to get mother involved with breastfeeding or kangaroo mother care. We still use the highest flow rate of 8 liters, and if it is exceeding that, we change to CPAP. And the lowest flow rate we use as 2 liters. If baby is stable on 2 liters of high flow, we stop it unless baby is going home on home oxygen for conditions like chronic lung disease or so. That's it.
Thank you, sir. I request Dr. Munra, sir, to please conclude the session.
Suresh, you were fantastic as usual. But machines which works more, but the brain behind the machine is important. As you rightly said, CPAP is more friendly, user-friendly in comparison to HFNC. Thank you for your talk.
Thank you.
So I have a question to ask you, sir. Does HFNC increases the infection rate than our conventional CPAP?
There are no studies to show that. There were few concerns, especially with, I think the UK trials have showed that they initially when they used the humidification associated issues, mainly those organisms were associated with improper humidification. But I think in last 15 years or so, those that side effect has not been observed. So in short, no, HFNC or CPAP, they do not increase any rate of infection, and these are all modern machines. The humidification is modern, so this will not cause increased incidence of infection whatsoever in babies.